Welcome back to the Rebel EM podcast, core content for anyone, anywhere, and just in time. This is Swami, and I am here again with our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, great to have you back.
Hey, how's it going, man? It feels like we're swinging into spring and things are getting a little warmer, which is really nice.
Yeah, it is really nice. We had a rough winter, but it is spring. Of course, this is not a weather podcast. This is core content emergency medicine. We've got a great topic that we want to dive into today, which is nitrous oxide toxicity. It's not super common, but if you know it, you know it. And I think that's why this is really important. As we go through this, there are identifiable pieces that makes this diagnosis relatively straightforward. But I want to start kind of with the background. So give us a little bit of background on nitrous oxide itself.
So nitrous oxide is a colorless, odorless inhaled anesthetic that has been used for centuries, particularly in the surgical world. Mechanistically, it can induce euphoria, anxiolysis, and intoxication via NMDA receptor antagonism. And that should sound familiar, right? Ketamine works in a similar fashion. During the late 20th century, nitrous oxide was increasingly used recreationally due to its accessibility and perceived benign nature. The modern day slang term, which you may have heard for nitrous oxide, is whippets, which tends to refer to the canisters that contain this agent and are frequently used as a whipped cream foaming agent. The real issue with this is that there's a perception that given its legal nature and the benign perception of nitrous, frequent use can actually lead to lasting and permanent neurologic effects.
As we're going to get into, we're going to get those lasting neurologic effects. Obviously, there is a medical use for nitrous. I used to work in an emergency department where we had this for procedural sedation. It's absolutely fantastic, but it is readily available. I think you can order it offline. You can get the canisters, which makes it really easy to access for a quick, cheap high. But again, if you're using it a lot, you can have some real problems. So let's get into that pathophysiology. If you're using nitrous oxide for a while, how does it actually cause pathology?
So apologies in advance. I'm going to be saying things like oxidize and moiety. I know people don't love those terms, but nitrous oxide toxicity results from its ability to oxidize the cobalt moiety in vitamin B12. This leads to a functional B12 deficiency despite adequate consumption and absorption. So that's key. It's not that you're actually deficient, you're just functionally deficient in B12. Now, functioning B12 is needed as a cofactor for an enzyme called methionine synthase. And this enzyme has two critical roles. One, it helps convert 5-methyl tetrahydrofolate to tetrahydrofolate. Tetrahydrofolate is essential for DNA synthesis. And secondly, it helps with the conversion of homocysteine to methionine. And methionine is needed to maintain the integrity of the myelin sheath of our axons. So, keeping all that in mind, nitrous toxicity leads to one, a megaloblastic anemia, and demyelination of both the dorsal columns and the lateral cortical spinal tracts. And you may remember from back in the day, at least when you're in the neurology clerkship or anything, but that's actually called subacute combined degeneration.
It's that second part that usually brings the patients to the emergency department. That megaloblastic anemia, obviously people can have anemia symptoms, but this is usually a drug of abuse of relatively young people who can tolerate pretty significant anemias without really having much in terms of symptoms. So I have seen a single patient with this who did have a megaloblastic anemia. Hemoglobin was like in the 10 range, but he didn't have any symptoms of anemia because 10 in a 20-something-year-old guy, really not that big a deal. But that latter part, the effects on the neurologic system, that's where we start to see the patients actually coming to the emergency department. So let's get into the presentation. When you get toxicity, when you get those myelin sheaths that are having problems with their synthesis, what do you see in terms of patient presentation?
So for this, we really have to go back to our first year of medical school. And once again, whenever I hear the term decussation or upper or lower motor neuron symptoms, I inherently cringe like a lot of other ER docs. But these patients will have a combination of both upper and lower motor neuron symptoms due to demyelination of one, the dorsal columns, two, the lateral cortical spinal tracts, and three, peripheral nerves. So let's take this super slowly. Effects on the dorsal column will lead to diminished sense of proprioception, your sense of space and self, vibration and fine touch. Effects on the lateral cortical spinal tracts lead to upgoing plantars, hyperreflexia, weakness of the voluntary distal muscle control. And then effects on the peripheral nerves will lead to numbness and tingling and weakness in a glove and stocking pattern. And if you recall, those are symptoms that start initially in the feet and hands that progressively spread proximally towards the ankles and wrists. So taking all this into account, patients may present with the following: difficulty with ambulation, positive Romberg, dysmetria, so difficulty with finger to nose or heel to shin, upgoing Babinski, and decreased strength and sensation in a glove and stocking pattern.
So as I mentioned, I have seen one patient with this particular presentation in the past, and his chief complaint was clumsiness. He said, I can't really hold a pen or a pencil the way I used to. I'm having trouble writing and trouble walking. That's what actually brought him to the emergency department was this kind of subacute, insidious onset of these problems. And he's like, I used to be an artist and now I'm having trouble writing my name because of this. And it gave us the diagnosis pretty quickly. And you're going to talk about diagnosis next. But this is what we really need to pick up. We need to pick up those clinical manifestations. These are clearly peripheral issues. When I say peripheral, they're not coming from the brain. These are coming from the spinal cord and below. We need to be able to localize that in order for this to enter into our differential. So how do you actually make this diagnosis? Is it just based on the patient having those type of symptoms, or is there more here?
So I love that story, Swami, because that's exactly how patients tend to present in my anecdotal experience. Patients tend to be on the younger side and they come in with vague but debilitating neurologic symptoms. And, depending on where you work, if you work in the Ivory Institution with 24/7 MRI or 24/7 neurology consult, this is not the patient you need neurology to make the diagnosis. You could make this diagnosis purely based on history and physical. As with a lot of pathologies in toxicology, identifying the exposure will expedite management. But let's pretend your patient isn't forthcoming, because frankly, they never are. A thorough neurologic exam will narrow the differential, with a particular focus to find peripheral motor and sensory deficits, dysmetria, proprioception, and inability to ambulate. From an imaging standpoint, MRI of the spine may identify enhancement and/or edema of the dorsal columns, specifically on T2-weighted axial imaging. This is sometimes referred to as the inverted V or inverted rabbit ears appearance. Serum B12 concentrations may be normal. Recall that the issue is a functional deficiency as opposed to a vitamin absence. However, patients in theory may have elevated concentrations of both homocysteine and methylmalonic acid, both of which are metabolized in the presence of functional B12.
My favorite part about this is that we can make this diagnosis based on the history and a quick physical examination. Sure, they should get a detailed physical exam as well, but we were kind of chatting about this before we started recording. And the patient that I saw, I only asked him two questions. Tell me what's been going on, and then do you use whippets? That's all we needed. And when you have a young patient who comes in with clumsiness, a gait abnormality, this is one of the things that you should be thinking about. And you can, again, get to the diagnosis pretty quickly. And my patient was very forthcoming. He was very honest. He's like, yeah, I use whippets all the time. And this kind of comes back to what you said earlier. People think these are relatively benign, almost like this isn't really a drug of abuse since I am legally purchasing it anyway. So because of that, I think patients often will tell you, yeah, I'm using them. They might not tell you how much they're using, but they'll tell you that you're using, and then that can get you to this diagnosis. Now, making the diagnosis is great, Sanjay, but we also want to be able to offer treatment. So what should we be doing once we suspect this in terms of management?
First and foremost, cessation of nitrous oxide abuse is crucial to limit/prevent ongoing toxicity. While there is really no universally agreed upon treatment regimen, supplementation with intramuscular B12 is recommended. And approaches really vary from daily to every other day injections until symptoms improve, at which point the injections can be spaced out to weekly and then monthly. Physical and occupational therapy may be needed depending on the degree of functional debility. Now, I'll tell you anecdotally, the 2 or 3 patients I saw during fellowship, they were in their 20s and 30s, and it was kind of like you said, they couldn't use their pen to write. They couldn't walk. And as a result, you may actually have to admit those patients for therapy and possibly subacute rehab as a result. And then lastly, it's important to note that depending on the severity and chronicity of toxicity, there's going to be some proportion of patients that may not actually fully return to their baseline.
Yeah, that's unfortunately exactly what happened with my patient. He did get admitted mainly to get that MRI done, did get some physical therapy in-house and then continued physical therapy, but never really returned to his baseline functional status, which is pretty impressive when you consider this is a young man, right? This is a 20-something-year-old guy who's now going to have a long-term disability. And Sanjay, that comes back to another important point, which is that if you happen to discover that the patient is using nitrous, doesn't present with toxicity at that time, it's good to advise that that is not a benign drug. That long-term use can lead to long-term morbidity, long-term disability. So this is a place that we can really kind of advise our patients as long as we kind of understand the toxicity here, understand the seriousness of it, and are also kind of on the lookout for it. It's not a question I always ask. I don't ask every single patient who comes in, are you using whippets? But it is something I add once they say, I do use controlled substances, I do use illicit substances, I will ask about that one as well. All right, Sanjay, let's wrap up with a couple of big take-home points on nitrous oxide.
Though legal and seemingly benign, nitrous oxide abuse can lead to permanent neurologic dysfunction. Nitrous oxide toxicity can affect the dorsal columns, lateral cortical spinal tracts, and peripheral nerves. This leads to a constellation of both upper and lower motor neuron deficits, particularly in a glove and stocking pattern. Deficits in proprioception and fine motor skills, positive Romberg, upgoing Babinski, peripheral numbness, tingling, and weakness. Magnetic resonance imaging may identify symmetric high signal intensity in the dorsal columns. Treatment includes vitro supplementation and physical/occupational therapy as needed.
And of course, we would be remiss not to mention always consult your local toxicologist. They can help with management. They can help advise in terms of what the workup should be, since the truth is most neurologists have not seen this and may only see one case in their lifetime. Whereas, as you mentioned, you knew about 3 cases during your fellowship. You saw these patients. So we really do want to involve a toxicologist to help to guide management. Oh, that's all for the Rebel Core Content podcast this week. We will, of course, be back in a couple of weeks with another cast. Sanjay, hopefully we'll bring you back on and maybe talk about a more common toxicity, but I do think this is a good one to add to our knowledge base to understand this toxicity. Until the next time that we're back, everybody out there, don't forget to stay safe.